So, hello, it's John Zweifler, medical consultant with Fresno County Department of Public Health. Dr. Vora is off this week again on a much deserved break. And let's see here, hopefully you're not seeing all of that. So I'm just gonna, what I'm was gonna do is start with, let's see. It's gonna, as last week we went through some of the numbers from for COVID in our county. I was going to do something similar again today. We'll go through it more quickly. So let's see if we can do this as well. So we can see our curve. So this was back in the winter when we had our big surge. We had the summer surge back here, and you can see the surge that we were in exceeded what we had last summer. We are starting to taper down, but it's been kind of slow. Our case rate is 26 this week. Last week it was around 28. So that it's tapering down, but not as rapidly as we would like. As well, we're also seeing some more deaths being reported. So this is again the typical pattern where you get the cases, then you get the hospitalizations, and then you start to see the deaths. In terms of our hospitalizations and ICU utilization, so last week our numbers were around 280 or 90 in the hospital, and we're down to 260, 262, so we're moving in the right direction. ICU was 57, down to 54, again moving in the right direction. This over here, and we'll be able to send this out later, so you'll be able to look at it at your leisure. But this shows how Fresno County ranks to the other counties. Last week we were behind San Bernardino. Now we're ahead of them in terms of total in terms of the numbers hospitalized in our county. So that's where, relative to the rest of the state, we're not dropping as fast as others. So we're disproportionately represented in terms of our hospitalizations. That's also the case when you look at our positivity rate and our case rate. So here's the state of California as a whole. So positivity down at 2.8. Here in Fresno, we're at 8. Last week, we were actually at 7.8. So this number has actually gone up. And you can see it's over 3 times as high as the state of California. We're in similar company when you look at the other counties in the Central Valley. So all of them clustered around where Fresno is. So the Central Valley has more work to do. You can also see that showing up in the case rates. So California as a whole, 12.9. We're at here in this particular data point at 26. So double what it is in the state of California. Just as a reminder, when we were doing the blueprint, we had the tiers. The purple tier was 14 and above, so California has actually dropped into red, which is nice, but we would still be deep purple. Turning to vaccinations, not a lot of change. So we've had about 2,000 a day over the last week. Some of the probably most of those are the boosters, which are available now to our higher risk individuals who got the Pfizer within the last over 6 months ago. So if you got the Moderna or Johnson & Johnson, you're not eligible for a booster. In a way, well, we'll see whether that changes. The FDA is looking at that data. The Pfizer data, the Pfizer booster was based on data which shows that you could reduce breakthrough infections from by about 40% by adding that third booster. We really haven't seen much drop off in efficacies in hospitalizations and deaths in preventing severe disease with Pfizer. So if you have not, that's good news for the Pfizer vaccine. And when we look at those 12 and over who've gotten the vaccine, which are those that are eligible right now, so we're at about 2/3 that have gotten at least one dose. And if you look at those who are 65 and over, we're above 90%. So really nice number. And if only all of us would listen to our elders and get vaccinated, we would be in a lot better place. When we look at our school age population, the numbers are considerably lower, not surprisingly, but if you look at the 14 to 17, pretty similar to what we see for the adult population. The 12 and 13-year-olds lower. But then when you look at the pediatric population as a whole, because most of them are not eligible, we see a much lower number. So today I wanted to talk more about kids and about schools. I was going to also talk about monoclonal antibodies, and I believe Dr. Nas from St. Agnes has also wanted to touch upon this, and then we'll touch briefly about the new oral medication that is in the news but not yet available. So when we're dealing with the schools, so as all of you know, so the last year school in-person school was rather limited. So classrooms were there was physical distancing was employed for those schools that were open. A lot of kids were doing were going to school virtually. But for this school year, the emphasis has really been on getting kids in classroom for that in-person education and the interactions that are so important to behavioral psychosocial development as well as academic development. So what we're dealing with in the schools is certainly following up a positive test. So that leads to contact tracing, identifying those who are within 6 feet of a positive case. And then those who are positive are isolated for 10 days. And what we're used to is if you're a close contact, then you'd be expected to quarantine. And again, that's in general, it's 10 days, but both CDC and CDPH now allow individuals to end quarantine after 7 days. They can return after 8 days if they test negative on or after day 5. The schools added something called modified quarantine. So this applied when there was a positive case and the positive case, the index case, and all of the close contacts were wearing their mask. And in that situation, the school said you could do modified quarantine, which basically means that the children can remain in school, but they were expected to test twice a week for 10 days, and they would of course have to remain asymptomatic, continue to wear their masks. In Fresno County, we said, well, at least make sure you get tested at day 5 if you're on this modified quarantine. The other big issue that we've have to deal with in the schools are children who are symptomatic. So, you know, if you have a cold or cough or congestion, there's such a long list of symptoms associated with COVID that's a real issue for our schools. And we've really, we've tried to be stringent and err on the side of being cautious because we are in the midst of this pandemic. So if kids have any kind of symptoms, we say you need to go home until you can be evaluated by your clinician and tested. And we'll talk more about that in a minute. So if you've been vaccinated, you don't have to quarantine. So that's true in the schools as well as out in the community. There's different rules that apply for students and staff. So students fall under the California Department of Public Health, but staff are part of Cal OSHA, fall under Cal OSHA guidance. So there's slightly different regulations, particularly around quarantining that come into effect. And then we have to deal with outbreaks. So cases in schools reflect what's going on in our community. We have a lot of cases in the community, so we have a lot of cases at the schools. We're not seeing a lot of transmission within the schools, but there are some. And so we work closely with the schools to identify if a case is whether there's any other potential likely source of transmission. So, for example, are they a close contact of a family member, or were they at a gathering where others were positive? If we cannot identify anything like that, then we become concerned about transmission at the schools and think about potentially quarantining classrooms. And this link down here takes you to what we call our school scenarios, or our K through 12 guidance. So for those of you who are interested, there's a lot of information in there about how we handle specific situations with the schools, and we meet regularly with the superintendents and the nurses regarding that. So the bottom line is, again, we want our schools to be open and to have in-person education for our children, just like our work. We want our workplaces to have that option as well. But at the same time, we really want to keep those classrooms safe, and so we again err on the side of being cautious with those who have symptoms. And so that's why we've really stressed that any individual who has symptoms, we really like those folks to get tested. And so that's where we really depend on you as the clinician community. So just to review what some of the testing options. So, there's both rapid antigen and PCR. PCR has to be sent out, so it takes longer. There are a few machines that are available that can do point of care PCR, but they're not they're very limited. So really, it's either rapid antigen that you can do in your office, or PCR that's sent out to a lab for testing, which you may get back several days later. So we've seen, the growth and availability of rapid antigen testing, but the rapid antigen testing is not quite as sensitive as the PCR test, which means you may get some false negatives on individuals who are symptomatic. So that's why the FDA, when they talk about rapid antigen tests, says when using rapid antigen testing, negative results should be treated as presumptive, and can be confirmation with a molecular assay, i.e. PCR, may be, if necessary for patient management, may be performed. So it's strongly encouraged by the FDA, but it's not an absolute requirement. And in Fresno County, we encourage, or we certainly support clinicians to use their latitude in deciding whether or not you need to get a confirmatory PCR. The difference in sensitivities during the symptomatic period between our rapid antigen and PCR is in the range of about 90% compared to 95%. So there's some increased sensitivity, but usually it's in those with lower viral loads are the ones that are going to get picked up by the PCR test. And so again, as you're evaluating patients, it's really just like with a lot of viral illnesses, it's hard to know exactly which one it is. But that's where clinical judgment comes in. As far as if you have a symptomatic individual who is positive with the rapid antigen test, then those the test is very specific, meaning there's very few false negatives. False positives. And so you do not need to confirm a positive rapid antigen test in the symptomatic individual. And it's so we really, the bottom line is we really encourage you to do, if you see someone with COVID, if at all possible, get them tested, because it's just so hard to sort out whether it's the COVID or something else. And because of the implications for public health and transmission of the virus within a pandemic. So if someone is negative for COVID with symptoms, then that means they're able to go back to their to work or to school once they become asymptomatic. And that's huge, because otherwise they would have to isolate for 10 days, and so they could be a week or more without symptoms when they could have returned if they'd been tested. So again, we really encourage you to test everyone you see, when there's any question of COVID. Another situation that comes up that clinicians are involved with is particularly in the schools, children who may have a chronic condition that leads to a COVID symptom. So someone with allergies may have congestion, or someone with a cough, with asthma may have a cough. Someone with some type of bowel motility issue may have issues with nausea or vomiting. So there is an option. So if you have a patient who has a chronic condition that is leading that is manifested with symptoms that overlap with COVID, then a note from their clinician can help them stay in school. So we do leave that as an option. And so you may have parents who come to you and ask, or workers who come to you and ask for a note regarding this. In terms of diagnosing COVID-related symptoms, so sore throat is also a symptom of COVID. So if you're able to provide an alternative diagnosis based on a diagnostic test, such as a positive strep screen or influenza screen, to explain symptoms, then that also would suffice in terms of helping us determine who has COVID and who doesn't. We have additional resources about schools. And so again, here's another link. We'll send this PowerPoint out so you'll be able to check that. But if you're interested in what's going on at the schools, it provides information on the school's safety plans regarding COVID, what type of testing is available at the schools in terms of PCR and rapid antigen, the nursing contact information, who at the school has been working on ventilation issues, and then what type of behavioral health resources are available at the school. So, a lot of mental health implications for all of us, I think, when through the pandemic and being stuck at home and isolated. I think it impacted all of us. So ensuring that there's behavioral health resources at all of our campuses is a point of emphasis for our schools, as well as for the Safe School for All program. So with that, I wanted to switch gears and I'm going to run through this next section, and then maybe I'll have see if Dr. Naz is available and can also contribute to the discussion. So they're monoclonal antibodies. There's 3 of them that are out there. There's Regen-CoV, which is a combination of casirivimab plus imdevimab, and then there's BAM and ETE is another combination that's approved. And then there's a third monoclonal antibody, sotrovimab, that's also available. So it's just going to talk a little bit about the monoclonal antibodies. So we've talked about them in the past. Regen is one that is preferred by the clinicians in our community who are administering the monoclonal antibodies. All 3 of them can be provided by IV infusion. Regen is unique in that it also can be provided by subcutaneous administration. So this slide, I won't go into details on it, but it does describe how you can do the sub-Q injections. It's actually, you have to give 4 injections during the same visit. So some people may prefer an IV infusion, others may prefer the sub-Q administration, but the sub-Q administration is an option for the Regen. The other development with monoclonal antibodies, so they've been have been approved for high-risk individuals who with mild to moderate disease who are COVID positive. But another indication has been added for both the Regen and for the BAM ETE, and that's for what's called post-exposure prophylaxis. So post-exposure prophylaxis is for those who have not been, it's for individuals who are not fully vaccinated or immunosuppressed. So with our immunosuppressed patients, about half of them don't really develop an immune response. So they're effectively not vaccinated. So the post-exposure prophylaxis can be offered to individuals who are not fully vaccinated or immunocompromised, and who also are exposed to someone who is COVID positive, i.e. they're a close contact, someone who has COVID, or they're in a setting where they have the potential to be exposed to, they're at high risk to being exposed to individuals who are infected with COVID. So examples would include nursing homes or prisons. So we're seeing that most of the utilization we believe is still for mild to moderate disease, and that's where it still makes a whole lot of sense. But there is this additional indication for those your patients who are not vaccinated, who are at higher risk, and who are basically close contacts of someone who's COVID positive, to receive the monoclonal antibodies in that situation as well. So I mentioned that there are 3 monoclonal antibodies that you have an option for. The Regen-CoV, again, is the kind of the monoclonal antibody of choice here in Fresno County anyway. But I did want to put a plug in for the other 2. And the reason for that is the federal government has changed how the monoclonal antibody is distributed. So before you could, as a clinician, you could order directly from AmerisourceBergen. They have now, the federal government is now, through HHS, Health and Human Services, allocates to each of the state a certain amount of the monoclonal antibodies, and then the states then allocate it to the local health jurisdiction. So in the example of California, it then gets passed on to Fresno County. So this has been going on for the last 3 to 4 weeks. We've been allocated the first couple of weeks around 300 to 400 doses. And the first week we had, most of that was in the form of Regen-CoV, but the amount of Regen-CoV that they've been offering has been dropping. And now they are there. And so this last week, they only had about 144 doses of Regen-CoV, but they had another 200 of BAM-ETE and now they've added sotrovimab as a third monoclonal antibody that's available. So, and as I was saying, all 3 of them, they're administered by IV infusion, and they're very similar efficacies. There is no difference in terms of the efficacy in reducing hospitalizations, reducing ER visits, deaths. All of them are in the range of 70 to 75% effective in that regard. So you can feel quite comfortable administering any of those 3 to your patients and having a similar clinical impact. But I think one of the reasons why perhaps there's been some hesitancy about the others, or with the sotrovimab, it wasn't available. And so it's just now become available in terms of the distribution process. So I think that contributes to that one. But for BAM-ETE, there's some history. And so BAM-ETE, as it was not as effective as some of the other variants that were out there that were circulating this summer. And so its distribution was paused during the summer. But now that Delta is our main variant, the BAM-ETE is actually quite effective against Delta. It's as effective against Delta as it is against the other strains. And so as of September 2nd, BAM-ETE is again available. So again, Fresno County is getting about 500 close to 500 doses this week from the state, but we're not getting requests for the BAM-ETE or the sotrovimab. So this just putting a plug in for using these other two agents as well. And these are just some other points regarding BAM-ET, which I pretty much already gone over. If you do have someone who's had a travel history, South Africa, Brazil, and Colombia, those are the areas where you would might have decreased susceptibility, and those would be the ones that you would want to would recommend something, either the Regen-COVID or the Sotrovimab. And so, yeah, I touched upon Sotrovimab, and I'll learn how to pronounce it by the end of this presentation. But again, it's also FDA EUA approved. And so I was mentioning about the efficacy of all of the three is fairly similar. You know, all these three have been tested very rigorously. I think that, you know, one of the kind of circulating myths is that, you know, that with the vaccines as well as some of the treatments as well, how could they have gotten this out so fast? And there must be something unusual going on. The emergency use authorization is designed to get things out quickly in an emergency, which is what you have when 700,000 Americans die from a single disease. But it still undergoes a very rigorous study. And so, for example, this is just the example from Sotrovimab, where they had 600 individuals. They, you know, phase 1, 2, 3, phase 1 and 2 are smaller studies, and then they go to phase 3, which is larger. This study was actually stopped because it was so, because the results were so definitive early. And so you can see that the, so hospitalization and death occurred in 7% of those who received placebo versus 1% who received the Sotrovimab. So impressive results. You know, select your patients carefully. The indications are actually pretty broad right now. So anyone who's obese is considered at high risk. So that covers you know, 70% of our patients. So be thinking about it with your patients with mild to moderate disease, not indicated for those who are requiring oxygen. So before I go to the next, is Dr. Naz on the call?
Yes, sir.
Hi.
How are you?
Very good. Yeah. Do you want to talk a little bit about what you're doing at St. Agnes? And
yeah, sure. So I did send over our newest order set, and it would be great if we could share that with this group. Essentially, you know, since opening our outpatient respiratory infusion room at St. Agnes back in December of 20, we've now treated more than 500 patients with great success. You know, our respiratory infusion room offers both the Regeneron product as well as the Bamlanivimab and Estevimab product, considering we have not been able to receive the Sotrovimab product just yet. But now that it is available, we likely will be ordering it. You know, we do know that there aren't currently any shortages of these antibodies, but due to logistical constraints and limited space, it can make it difficult to administer these agents to all of the eligible patients. And due to heavy demand, only patients meeting criteria will be scheduled at St. Agnes on a first come first served basis. We are now open from 7 a.m. to 5 p.m. daily, Monday through Friday, and we do about 15 a day for these past couple of months. And you know, the reason I really wanted to talk to this group was, well, twofold. One is that NIH has created a new treatment guidelines that prioritize the treatment for both patients who are COVID positive or for prophylaxis, as you mentioned. So those priorities are divided into 5 different categories. And our order set now defines which category of patient that you're sending us. So really, I think there's 2 takeaways from this. And the first is our new order set contains cleaned up instructions on how to order monoclonal or polyclonal antibodies. And that's by first calling to schedule the patient, and then second, to complete the order in its entirety and then fax it over. So, you know, as you know, St. Agnes Medical Center also sees patients of all different kinds and receives orders and faxes for various reasons. So, I think it's wonderful that we have many community docs that are now providing polyclonal antibodies. But for us specifically, our scheduling team definitely needs the provider to do his best to fill out which priority level, as well as certain other indications, including the date of symptom onset and days since symptom onset, as well as the positive test, or whether or not it was whether or not they're being administered this medication for prophylactic use. We want to get every single patient we possibly can this medication that needs it, but due to heavy volumes, it's become really important for providers to fill out the order set completely. One of the things that we definitely have done is allowed for non-medical staff members to use our service, and so we try to make the order set as easy and as succinct as possible for those who don't necessarily or usually send their patients over to St. Agnes. So we greatly appreciate the community support in sending us their patients, and we've seen tremendous value in this medication. We've had patients who looked fairly sick and felt fairly sick when they walked into to the infusion room, and about halfway through they say, I feel like a new person. And so that is touching for all of us, and St. Agnes Medical Center greatly appreciates that. So I urge you to take a look at our order set, and please do fill it out to the best of your ability. There is a phone number to call the scheduling department. There's a phone number for the fax, and if anyone has any questions or concerns regarding our outpatient respiratory infusion room, there's a phone number there as well to speak with Dr. Raquel Yankee, who's our medical director for our outpatient services. I'm happy to take an email or phone call as well, and I know Dr. Egerton, our chief medical officer, is on this call, so he would also be happy to take anyone's questions or concerns regarding our administration of polyclonal antibodies.
Well, thanks, Dr. Nas. Really nice presentation, a really nice order set too. And I really appreciate that you open this up to clinicians who are not members of St. Agnes Medical Staff. I think it's really, this speaks well of St. Agnes. And it's not, we don't have the monoclonal, polyclonal antibodies available at all of our hospitals. So it's just great that St. Agnes has really stepped up in this regard. We have a number of clinicians who have in our community who just basically volunteered to do it, and so which is fantastic, and we encourage others to as well, and we'll walk you through that process if you're interested in doing that. But it's something that we should be offering to our patients, and certainly if you're part of an organized delivery system, there really should be processes in place to ensure that your patients have access to this type of treatment. And so again, hats off and thanks to St. Agnes for being a bulwark in our response. And as he mentioned, that basically with the monoclonal antibodies, you're vaccinating someone instantaneously. So they're immunized, that you're giving them immunity. And you don't have to wait weeks for it. And so you see these reductions in hospitalizations and deaths that you see with when you compare vaccinated and non-vaccinated. So it's very impressive. Would be easier to get vaccinated, but for those who are at high risk, this is a great option. Are there any questions for Dr. Nas or myself regarding the monoclonal, polyclonal antibodies? And Dr. Nas, you pronounce them much better than me. Thank you.
We've had to practice.
Okay. Well, so you know how to get a hold of Dr. Nas, and we'll try and make this, Dr. Nas, would you like us to make this order set available? We could certainly send it out after this meeting. So,
absolutely. Share it with your physician friends and colleagues, and that's it.
Yeah.
it looks like Dr. Yankee is also joining us on this call. So she's also willing and happy to take any questions regarding our polyclonal antibodies.
Yeah. The sooner you you administer them, the better, once they have mild to moderate symptoms. So you have all those kind of questions in here. All right. Well, thank you very much, Dr. Naz. I'm just going to continue on, and we're getting near the end. I was going to talk a little bit about a medication you might have heard about, molnupiravir, which is the oral medication that Merck is working on. And so the reason why people are excited about this one is it's an oral antiviral medication, and we've heard a lot about the spikes on the COVID virus and how that's where our vaccines work. Well, this one works by preventing the virus from replicating in a rather complicated way. And for any of you who remember their biochemistry or would like to brush up or would like to read more, here's a link. But it inhibits viral replication, and in this regard, it's similar to remdesivir, which is another antiviral, which is for COVID, which can be used for hospitalized patients. So similar to the antibodies that we talked about, is for the treatment of mild to moderate COVID in at-risk adults. In the studies that they did, they defined their higher risk adults as those with obesity, elderly, and diabetes. And the results are maybe not quite as dramatic as with the monoclonal, polyclonal antibodies, but you can see reduction of about 50% in terms of risk of hospitalization, and very impressive reduction in deaths from 8 to 0. In terms of adverse events and discontinuation rates, very similar in both groups. We don't know exactly what will be approved in terms of dosing, but it'll be probably very similar to Tamiflu, where you prescribe it for 5 days, beginning as soon as symptoms develop. So this one's going to probably take a couple months to go through the approval process, but it's something that we can look forward to. But we would still just prefer that you get folks vaccinated. Speaking of vaccinations, so probably all of you are dealing with this, that as of 2 weeks ago, September 30th, all healthcare workers in California were expected to have completed their vaccine series. There are exemptions for sincerely held religious beliefs and medical exemptions. The medical exemptions are very limited. You're basically just having severe allergic reaction to one of the elements of the COVID vaccine, or a hypersensitivity reaction to the COVID vaccine itself. So not a lot of medical contraindications. The medical and religious exemptions apply to the vaccine. They do not apply to testing. So anyone who has a medical or a religious exemption is expected to test. If you're in a hospital or SNF or high-risk setting, that's twice a week. If you're in a doctor's office, other healthcare settings, that's weekly, and it can be either rapid antigen or PCR. The state of California did expand this mandate to in-home hospice and senior centers healthcare workers recently. So, but then for those folks, that the deadline to complete vaccinations is November 30th. So that's all I had for today. Be happy to answer any other questions that you might have about anything that we've touched on. And if not, we'll send out this the presentation, and we'll send out the order set from St. Agnes as well. Okay. Yeah. Well, thanks everyone, and hopefully we'll have Dr. Vora back next week, and he can take it from there. But the Fresno County Department of Public Health is always available for any questions or concerns that you may have. Thanks for joining. Bye-bye.
Dr. Z.